if you want something to do while you're waiting, please share the YouTube link around. It's also on the YDHF homepage, but that YouTube link, yeah, if you want to share on any social media. For anyone that has joined the stream, we are live in about 3 minutes and 35 seconds. It's pretty precise there. Please do share our YouTube link around. Anybody with that link can watch on. And if you do have comments, put them into the YouTube comment section. That can go for questions or anything that you might want to add as well. And we can read those out and ask those questions to the presenters. Thank you. Good afternoon and welcome to our first Yarra Drug Health Forum online from quarantine, from isolation, wherever you're listening, in your lounge room, your living room, your sunroom, I don't know, whatever nice room you have that your computer's in. This afternoon we are going to be speaking or hearing from a number of guests, and we will be taking questions, comments, anything like that that you have. Please put them into the YouTube comments feed, and we will get to them. My name is Nick. I work at Harm Reduction Victoria with the Dan's Wise program. Also present a weekly radio show on Melbourne's 3CR, 855 AM 3cr.org.au, and that's on Sundays, called In Psychedelia, where we cover a lot of drug issues and drug policy issues. The Yarra Drug Health Forum... actually, no, I'm going to cross to Peter now, who is going to do some introductions for us. Peter, welcome.
Thanks, Nick. Welcome to everybody that's online and listening to this Zoom telecast or YouTube telecast. Firstly, I'd like to acknowledge that all over Victoria, we're meeting on Aboriginal land. And where I am, it's Wurundjeri land of the Kulin Nation. And I'd like to acknowledge elders both past and present. I'd like to acknowledge that this land that we're meeting on was never ceded, was never willingly given, but was taken. And we look forward to the day when Aboriginal culture and Aboriginal sovereignty is acknowledged, both legally and constitutionally. And look forward to the day when we can have a meaningful legal and cultural reconciliation with Aboriginal people. Look forward to building strong relationships with the emerging and continuous leadership of the Aboriginal community in Victoria as we move forward. So today is a really important day. Firstly, it's the first ever live Zoom YouTube telecast of the Yarra Drug and Health Forum. Yarra Drug and Health Forum has a long history in bringing and raising issues around drug and alcohol and community-related issues as they interface together. It's got over 20 years of dealing with all sorts of issues, like the role, as we're discussing today, the role of peer education and people with lived experience in working and contributing and informing the world of drug and alcohol, community drug and alcohol treatment, and the policy frameworks around community drug and alcohol treatment. When I started working some 43 years ago on drug and alcohol, Alcoholics Anonymous and Narcotics Anonymous were really crucial organisations that supplied people with lived experience into the sector and supported people who were working in the sector to make valuable contributions to the recovery and to the humanity of the treatment sector. And some 40 years later, we still seem to be having that same discussion about how all this fits together and how best people with lived experience contribute to the professional setting of treatment and treatment services. If it wasn't for HIV and the rise of HIV, I'm not sure where we'd be, but HIV gave a great impetus to validating and allowing people with lived experience to come forward with their wisdom, their knowledge, and their understanding of how best we reach out to communities to bring them into the discussion around how best to deliver services and involve people in conversations that have that special knowledge and understanding that only people with lived experience have about those sorts of circumstances. So today we've got a great panel. We've got a great bunch of speakers from the academic world, from people who have years and years experience in harm reduction, and for people who have really thought long and hard about the value of having peer educators, people with lived experience, and the interface between the treatment sector and people who have come from that background. So I'm going to hand it over to Nick, and he'll be comparing the rest of the day. So I look forward to hearing from the panel. Cheers, guys.
Thank you very much, Peter Wern. There is the chair of the Yarra Drug and Health Forum Executive, and I just wanted to let you know, if you haven't checked out already, there is a new website for the Yarra Drug and Health Forum. The URL is ydhf.org. and there you can find information about how YDHF works, what has been done in the past, and also ways to get in contact with the Yarra Drug and Health Forum. And also, just quickly let you know if you do have questions, just to sort of guide the values of the Yarra Drug and Health Forum are to reduce the harmful impacts of drug and alcohol misuse by promoting evidence-based, humane and compassionate policy and program approaches. So that's what we're going to be hearing about today. And our first speaker this afternoon is the Executive Officer at Victoria's Drug User Organisation, Harm Reduction Victoria, Sione Crawford. Sione, welcome.
Hi, thank you, Nick.
And I have your slideshow ready as well. So, Sione, okay, when you're ready.
Cool. Thank you. Thanks for that introduction to Peter and Nick. Really glad to be here today. I'd like to acknowledge that I'm on Wurundjeri land today, and I'd like to acknowledge them as the traditional owners of the land that I'm on today, and also pay my respects to their elders past and present, and Aboriginal elders of other communities who may be with us today as well. So as I said, thanks to the Yarra Drug and Health Forum for having us speak today. It's a kind of an odd sort of way to present. Normally you're in a room with people and you can get some vibrations and stuff like that. So I sort of feel like I'm speaking into the void right now, although I can see some of my co-speakers with me. So bear with me. So again, thanks to Yarra Drug and Health Forum for having us here to speak today. Look, for simplicity's sake, today I'm presenting on the W3 framework and project, which is the what works and why framework. But Dr. Graham Brown is here with us as well, and is here to answer any questions afterwards that I may not be able to answer, and potentially clean up any of my errors as we go along as well. And the framework is largely his work, and as we'll see, he's collaborated really inclusively with the affected community as he's undertaken this work. So in the few minutes we have, it's a pretty formidable task to outline this framework and how Harm Reduction Victoria has utilised it, but here we go. Next slide. So the mobilisation of communities in health promotion is often underpinned by investments in peer and community-led interventions and advocacy. For example, such investments have been central to the global response to HIV and Hep C. Despite this, community and peer-led programs, such as those conducted by organisations like Harm Reduction Victoria, continue to just have limited capacity really to demonstrate our role and our value as part of a larger system. While the W3 work that we're discussing today is largely framed in relation to peer bloodborne virus response and prevention, as Peter pointed out, the HIV response has been peer engaged for much of its time in Australia, and hepatitis C is as well. And Harm Reduction Victoria is in partnership with APSTU also trying to apply these learnings from our bloodborne virus peer work, along with those of Shark's peer workforce development in the treatment sector, to furthering the AOD harm reduction peer workforce, which we'll talk a little bit about today as well. Next slide, Nick. I can't dwell too long on this point, but it's really important to remember that Harm Reduction Victoria itself is a peer-led organisation. And it's useful to remember as I speak that our team are all peer workers, including myself. I may be the EO, and I might be removed from the day-to-day peer education now a little bit, but I still consider myself, and I think it's importantly, I hope that I'm considered to be a peer by my community as well. So that slide really just has a really quick summary of a bunch of the work that we do across the sectors, across harm reduction and across bloodborne virus, but I don't really have time to go into that. And hopefully, if you don't know of our work, you can head along to our website, which is www.hrvic.org.au. And if you know of our work, great. Next slide, please. The W3 project took a systems approach to develop a program theory for peer-based programs to help guide our planning, evaluation, and evolution in a rapidly changing social and biomedical environment. The W3 project worked with a number of peer-based programs across Australia. A number of peer-based programs across Australia are affected by HIV and hepatitis C. It drew on systems thinking and complex adaptive systems to help us bring some clarity to the complex relationship between peer-led programs and their changing environments. And the context within which we're working is that of a community peer-led organisation with a load of peer and other skills, but lacking in time and research capacity, working in a really, as we said, quickly changing social environment, that of people who use and inject drugs, and a revolutionary medical environment as well, in which a cure for hepatitis C is not only available, but actually finally on offer to people who inject drugs and people who use drugs, which was not the case for many, many years. Not only was there not a cure, but people who inject drugs were effectively locked out of the treatment that did exist. Next slide, please, mate. So we'll talk I'm talking really today about the fourth stage of W3, which is up on the slide, I hope, and about why linking peer workers into a peer or lived experience organisation is important, not just for their own support, but to ensure that their work influences policy and the organisation, so that the work and learnings of other peers and other circumstances can influence and support their work in turn. In practical terms, this might look like a community practice, but it's really one that's mediated as well by organisational learnings and policy, as well as those of the participant peer workers. One way that we understand the impact and the quality of our work as we do it is to draft meaningful indicators. And I'm sure everyone attending today has experience of indicators that are less meaningful or a holdover from earlier times and are about things that happened before rather than things that are happening now. Some of the key work that Graham and the W3 project has collaborated on with us is on making these actually useful and as real a time as possible. Next slide. So one of our key, I think I've got mixed up with my slides. Hold on.
We've got the 4 functions, things that need to be happening for a program to be effective.
Sorry, yeah, I've lost that slide. Hold on. Sorry, mate.
That's all right.
I can't see it. I've got to kind of read it. Just give me 2 seconds. Sorry, guys. Of course, there's a glitch, naturally. I've got it in front of me.
As we wait,
sorry about this.
Just on the comments there, any jittering on the video is due to, unfortunately, I've checked my bandwidth this morning. It looks all right, but as probably most of you have noticed, coronavirus has increased demand on people's internet services, and a lot of people are video streaming and things like that at the moment. But from what I understand, the audio should be nice and clear. And just wait if it's jittering, and blame Australia.
Oh, good. All right, I found my slides. That's great. For some reason that didn't print. Don't ask me why, but whatever. So this slide is, well, I can't even read the title of it now, but this is about the functions really of the system, the W3 system that we're trying to speak to. And as I said, it's a pretty complex system and not one that I can explain in a few minutes and talk about how it impacted on HRVIC. But this slide really, the 2 parts that are highlighted are the parts that I'm really looking to talk about, and that's about engagement and learning and adaptation. And so the functions in W3, and again, Graham's here to sort of describe this a bit better than I can, but we understand that how a peer worker in our work engages with our community is influenced by our community and is based both on these community inputs from our community and by the peer workers that are involved in that program as well, which then in turn takes these inputs and re-engages with our community. There are 4 key functions that need to be happening for a program to be effective and sustainable in a constantly changing environment, such as the hepatitis C treatment environment, which is where we first applied these principles. And the first function is engagement, which can be defined as the different ways the program or organization engages with our community and maintains like up-to-date mental models of the diversity and dynamism of the different things that are happening really in our community. So whether that's needs and experiences or different identities of people who are using drugs. This also really importantly includes the peer staff's own ongoing experiences in the community. Alignment is how the program picks up signals about what's happening in the policy environment. And in more depth with learning and adaptation functions, this is about how the program uses peer skill to change and refine its approach according to what it's learning from engagement and alignment. And it's really important. I think I like the way that peer skill is defined in this process. It's the unique element of, peer-led programs. It's about the capacity to draw on a personal lived experience, but combine that importantly with a deep understanding of the changing broader environment, peer environment, and to use that to engage and influence peers, our networks and our community, as well as respond and think about and predict implications of change in the sector. And the last couple of, and I'll talk to that in a moment, and the last couple of functions are around how that work influences the community, how it's influenced by the community, and how it influences policy. Next slide, please, mate. Cool. So there's a lot going on this slide that's important to the framework, but we're focused on the areas sort of very inexpertly circled by my crooked highlighter. Really what we're looking at is how to measure a virtuous circle in peer engagement with our community, utilizing the peer skills we talked about before, informs and is informed by the organisation, in this case Harm Reduction Victoria and our peer programs, which in turn is informed by the community and in the model more broadly by policy inputs. Remembering that the community is diverse and dynamic, and there are multiple peer workers providing multiple inputs into Harm Reduction Victoria, who should seek to learn and adapt according to these inputs, which are in turn shared across the peer practitioner workforce. So in this way, peer workers support and are supported by the other peer workers that are part of the peer organisation. The other parts of the diagram speak to the wider environment the organisation is part of, and which the peer workers are influenced by and influence. So just to repeat that the concept of peer skill is the unique element of these programs, and it's about the capacity to draw on your personal lived experience, but also combine that with a deeper understanding of the changing environment, which is partly provided by being part of an organisation, and a peer organisation at that. Next slide, please. So to try and not only measure this, but also develop measures that would assist the organisation to learn and adapt based on the community, we use the functions as key areas. And due to the systems nature of the framework, the focus, as I mentioned before, was on indicators that are both about quality and impact that was happening, and not stuff that happened previously. And that's important because we are using this as an ongoing way to inform the programs that we are working on, to make sure that they are up to date and accurate for a changing environment, especially a quickly changing social environment, but also, as we mentioned, a biomedical one in terms of Hep C. We then develop tools, practices to enhance the data to make it more useful and meaningful, essentially what I was just saying. Next slide, please. So this slide really just outlines, I won't speak to all of it, but it really just outlines the way that we developed different indicators using different sources and data to really do the things we were just talking about. So one of our key peer educator programs is the Peer Networker Project, which seeks to engage networks of people who inject drugs to ensure they've got access to sterile equipment in their community, as well as harm reduction and bloodborne virus prevention, testing and treatment knowledge. And helping us to visualize this flow of information, influence and engagement, W3 assisted us to build meaningful indicators for this program that we can use both to learn and adapt the program to changing and up-to-date circumstances. So this is about utilizing real-time information flow to adapt and respond to community and to policy systems. So the health promotion, this is a really simplistic example, where the health promotion peer team can utilize the indicators such as the changing nature of people who inject drugs being reached, or the range of topics discussed to tweak or develop training and messaging as they do their work with the Peer Network Project. For example, we learned very early on that people who inject drugs very early on, in the Hep C treatment, once the Hep C cure was made available, we learned very early on that peers were actually becoming kind of fatigued with the messaging around Hep C, because we sort of overdid the messaging a little bit, and so we're able to use that to sort of in real time pull back and not only change the messaging, but actually use that to inform broader health promotion projects across the sector and the organisation. Next slide. And I might just get you to skip that slide as well, Nick. So the next one as well. So today, I think a lot of people are here from the AOD and harm reduction space. And the following speakers following on from me will include people involved in the Reducing Harm Through Peer-Led Networks program. That's a DHHS funded program, which is also supported by Harm Reduction Victoria and APSU. And APSU, which is the Association of Participating Service Users, are partnering to develop, I hope, a peer workforce strategy moving forwards. At the moment, Harm Reduction Victoria and APSU are also building a support mechanism for peer workers who want to be involved in that support, so that we can continually apply some of the learnings that we had from W3, but also from Shark's peer workforce strategy and their community of practice work, to build communities of support for harm reduction peer workers, which have not been as robust as they could be in the past. So, as I said, we're utilising the Shark peer workforce strategy, along with APSU and HRVic's decades of organisational experience in supporting peer workers. So we know that what's needed, well, actually, let's just move on to the final slide, Nick. So the rapid changes being experienced in hepatitis C has tested the adaptability and effectiveness of the whole response, including peer-led programs and leadership. We, through the W3 program and through working with Graham, have come to understand some of the systems ways that we can, some of the ways that we can respond and be a more responsive and learning peer organisation, how we can support our peer workers on the ground through real-time on-the-ground insights, which I've tried to reiterate all the way through here. This is even more important moving forwards, both in hepatitis C and bloodborne virus, but also in the AOD harm reduction peer sector, peer workforce sector as we move forwards, given there are numerous challenges that are in that exist for rolling out a workforce across that sector. So to value these peer-led programs and the participation of people who inject drugs and use drugs in these programs moving forwards, we need to not only value and draw on these effective peer insights and our leadership, we also understand your role as a broader sector in ensuring their effectiveness by supporting our organisations. And within that, we need to also invest in strong peer organisations and in a peer workforce strategy that links up the different sectors as well. And hopefully that's the work that we'll be doing with APSU if we're funded moving forwards. I think it's really important. There's been some great work done by the peer-led networks in the Reducing Harmful Drug Use and through Peer-Led Networks project across the last few years, and it's really important that we have an understanding of what that's going to look like moving forwards. There's been quite a bit of instability in that program in terms of knowing what funding exists. The DHHS has supported that program to the extent it can, I believe, and we've put in some submissions and some ideas about how we can work together to improve, to continue that program and work with peer workers and the sector to make that a really solid and strong program for the sector moving forwards. But it really does need to be in partnership with the peer organisations, as I've discussed. So that's my lot. And the last slide, Nick, if you could just flick it forwards. I think it's the last one. I've got it right this time. It's just a link. It's not just. It is a link to the paper that Graham and others have written around this as well.
Excellent. Thank you very much, Sione Crawford, who is the Executive Officer at Harm Reduction Victoria, and want to introduce now Graham Brown as well. Graham is the Associate Professor at the Australian Research Centre in Sex, Health and Society at La Trobe University. And he has worked in health promotion research for over 20 years with a focus on peer-led programs with affected communities. And I'm just bringing up Graham now because, of course, something happened when I had all my configurations right and then it buggered it up. But there's Graham's face now, and we'll put him in the right spot as well. Graham, welcome as well.
Thank you, and thanks, Sione. That was excellent and somewhat more brief than my waffling usually happens when I present. And look, I'm really just here to assist with any questions or discussion and so on. The guts of W3 was really about trying to find a much easier and much more effective way that peer organisations could evaluate programs in the resources of the organisation. And that was a big part. One thing I'd recommend people to have a look at is Harm Reduction Victoria's annual report, which is online, has amazing examples of really just how they've applied it in a very direct and simple way. So I'd encourage people to have a look at that to get a feel of what it's actually looked like in practice.
Website is hrvic.org.au, and you can go and check out some of the resources there. So I haven't had actually any questions come through other than technical questions on the stream so far. If you do have a question right now, please do drop it in. But I'm wondering, Peter, have you got anything, any questions that you have been thinking of as we've been going through Sione's slideshow?
I think my question would be for Graham. Graham, in the work that you did with the participating organisations around thinking about this issue, what was the thing that surprised you most about the work that you did? What did you discover that maybe you didn't think that you would discover?
Probably two things. One, that I found that as Sione said, look, there's a whole lot of terms used around systems and complexity approaches and so forth. And one of the key things we're really trying to do was reflect the accuracy of what's actually going on in peer programs. What I was really encouraged by was it makes sense when you think about it. Those that were closest to the ground, so our peer outreach workers, understood what we meant by working in a complex environment, perhaps more quickly than a lot of my academic friends, put it that way. So they got what the project was actually about. A lot more quickly. The further away you are from the programs at policy level, the nuance and the complexity of what peer programs actually do gets lost.
Yeah.
I'm curious as well, Graham, about that. So the further that people get away from peers, so does that mean that there are sort of different definitions of what a peer is floating about the place, because there might be different interpretations based on how directly people are actually engaging with that audience?
Look, firstly, I suppose one of the things that Sione mentioned was what often gets lost is the role that peer organisations and peers play beyond the people they're directly engaging with. So certainly we understand at a community development level, the sort of broader influence, if someone's engaging with their peers, then those peers engaging with others, that diffused impact kind of aspect. But also what gets lost is the impact that peer organisations have by sharing their knowledge with the rest of the sector, and the kind of shifts that can happen to actually get a more effective overall response. What often happens is peer programs get looked at in isolation as though they're they're simply an education program or so forth. I'm sure everyone that's listening today, and certainly all my co-speakers, know that they've always been far more than that. One of the other challenges we had was the idea of peer skill. Just briefly, what it came down to was getting a better understanding of peers in the context of the role they actually play, rather than getting caught up around who is or isn't a peer. So it's about, does a peer have enough personal experience and engagement with broader community and understanding of their broader community to actually play their role. There's so much diversity amongst people who use drugs. No single peer can be everything to everyone. Therefore, they need to have that sense of that, I suppose, the network of both peer workers, but also deep engagement with the community more broadly to be able to achieve that.
Can I ask Sione a question?
Yeah, and I think that last point's a really important one, though, in the context of looking at the screen with basically a bunch of men that are going to be speaking today.
Yes. Yeah.
There's a real problem with that.
Yes. So the question I have for you, Sione, I could imagine that leading a peer-based organisation, and the only real major peer-based organisation in Victoria around drug use, the diversity of that community is immense. How do you go about reflecting that diversity as an organisation that has the representation, responsibility, and the voice of that demographic responsibility? How do you represent that community?
I think it's important to state that I don't think one person really can, and we do have to think about it in terms of an organisation. But I'm wheeled up here today, but definitely try to share that load with the people across the organisation who know more about what's going on than I do on the ground. I don't think there's too many hands put up to sort of try and explain W3 in 10 minutes, but I certainly don't know if I did a great job of it, but I do know that the organisation is evolving and developing, and exactly as we've talked about, it may have started as an HIV organisation. Hep C became a more important thing for people. Well, I shouldn't say more important. It became a more pressing issue for people who inject drugs in Australia as time went along. And Harm Reduction Victoria has done a great job of opening itself up to things like DanceWise and the festival harm reduction work as well. And I think it's important to state that even then, as an organisation that's funded with, that might have sort of 10 or 11 full-time equivalent positions, it's literally impossible to represent everything. And the best we can do is say, this is the way that we should work together with partners like APSU, with Living Positive Victoria, with other organisations that are like-minded, but also with sector and AOD partners to come to understand their clients as well, and then apply. And I think that's the important part of W3 and the findings that we have from that, which is, well, some of the stuff that it shows that we already knew, I suppose, and that was part of I think what really propelled Graham to do this work, is that we sort of instinctively understood the way that peer organisations work is to bring together a bunch of people with different but similar lived experiences and then share and compare how those work. And that's really, I suppose, a peer organisation in a nutshell, and what we just strive to keep on doing. The more money we can get, the more we can do of that, and the more volunteers that we have. DanceWise has over 240 volunteers. I can't claim to know all those people, but they all have some kind of an input into our organisation, I hope.
All right, I think we'll introduce our next guest now. You are on Yarra Drug and Health Forum's first online forum. My name is Nick, and we've just been hearing from Sione Crawford, Executive Officer at Harm Reduction Victoria, and Dr. Graham Brown from the La Trobe University Sexual Health and... I've lost the full name of it, but Graham as well. And we're going to be hearing now from a peer worker out Geelong way. David Devine has been actively engaged in the community services / welfare sector since the late 1980s. That's like 30 years of experience now. I keep doing that. Having spent the last 2 decades, three decades now, working exclusively within the AOD harm reduction arena, while also wrestling personally with multiple addictions, David brings a wealth of insight and compassion born of lived experience to his professional practice. David is currently employed by Barwon Health's Drug and Alcohol Services Harm Reduction team as a peer overdose response worker. If you do have any questions for David as we're going along, please drop them into our YouTube comment section and we will get to them. David, welcome. Oh, that's Danny, but we'll have David in 1 second.
Thank you, Nick. I'm not sure if you can see me on the screen yet, but thanks for that introduction. And I'd also like to acknowledge the traditional owners of the land that I'm currently on, the Wadawurrung people, and their leaders past, present and emerging. Yeah, so as Nick said in the introduction, I've been exclusively working in around harm reduction for the last almost 20 years, and that's been with needle and syringe programs, mobile outreach program, homelessness support for people with AOD issues, and I'm currently working as a peer overdose response worker with Barwon Health. And so, yeah, I just wanted to talk a little bit about, I guess, the personal experience of a peer, and really some of it is echoing what the other speakers have said beforehand, that peers have lived experience, and that's really valuable depending on how you apply that to the work that you do and that you're engaged in. It doesn't necessarily mean that you have all the answers. Like there is such a vast kind of diversity amongst the peer space. Like Graham's research has acknowledged that it's not a one size fits all kind of solution by any means. And like in any kind of counselling or welfare, or helping profession, it's that use of self. It's you have to be really clear about what you're bringing to the picture, and not assuming that necessarily that you've got answers for other people or that you know what's going to work for them, but it's using that insight that's been kind of hard won. And so some of that journey for me, just in acknowledging that, there's the whole shame and stigma and discrimination is a big part of it as well. So people that have used substances, no matter where you are in that kind of journey or experience, whether you're actively using, whether you're occasionally using, whether it was a long time in the past or whether it's still, currently what you're doing in your life today, when you talk about that and be open about that, there's a real power in it, and I think that that's something that peers bring to the table that's unique, that we all have our lived experience, and it's not something to be kind of ashamed of. It's been part of like forming who you are and your life experience, and it's shaped the lens that you see life through. And so to kind of like keep that secret or hide it away or feel uncomfortable in owning that, I think is a detriment to workers and to the space, to the AOD sector. Like, I'm not sure of the stats. I read this a long time ago, but it's well known that for many people that are involved in the alcohol and other drugs kind of sector and that work, that they've had their own experience. It's kind of what's piqued their interest. They've had their ups and downs, or they've gained a kind of insight and a compassion for people that are, dealing with those circumstances and those issues. So, I know personally, I've sat in meetings and had co-workers or whatever kind of quietly laugh about their own experiences and share things that they've done themselves. It's part of the human experience. It's not something that we should ever feel ashamed of, I think. But knowing that intellectually is one thing, but then kind of, so for me, I've worked in the organisation for a long time, and I've worked as a clinician, I've worked as an outreach worker, but when I put my hand up for the peer role, there were some people that were kind of surprised by that. They didn't really know that part of my history, even though, I alluded to it or I had, spoken about it in confidence to people that I trusted. But, there were sort of like some raised eyebrows and a bit of confusion about, how do we treat you now? How do we refer to you now? And, in some ways it was a bit of an easy win, I think, like for the organisation, that it was fairly safe. I was a known quantity, and they knew my capacity, which really, puts me back to when I first started in welfare and gives me kind of empathy for people that are entering now and coming in with perhaps the label of peer. There's been some talk around stepping out as a peer, that it can even be stigmatising in a workplace for people to know, that's the peer. Geez, I wonder what they've done or how they got to be here if someone's not so comfortable talking about that. And I remember being at a conference a couple of years ago, a Shark conference, and it was Graham Panther talked about that difficulty sometimes of being the peer in the organisation, and when you're the first peer or the only peer, then, you know, you can kind of be dismissed a little bit like, well, that's the peer and that's the peer's opinion. And then if you get a second one on board, and so there's two peers, then, you know, those peers can be played off against each other. Well, that's what that peer reckons. And but let's ask the other peer. They've probably got different points of view. So sometimes you need three or more to really make it work, so that people can kind of see that, you know, there is this diversity amongst peers. And, you know, I don't know everything. I can't pretend to know everything. The key to lived experience is that is my experience. Sometimes that's translatable into and valuable for other people, but not always, you know. So I think, you know, it's a bit of a warning, I guess, to peers and people entering into the peer space. The last thing you want is kind of peer heroes, you know, people that think that they kind of know it all and they're projecting from their own experience that this is going to work for you and this is because it worked for me. You know, I was really clear about that when I first entered the workplace, that there's a lot of people kind of that haven't necessarily resolved their issues or don't have a deep kind of insight into themselves, and you can really easily like project what you think is the solution and what you think people should do, and really parentify the way that you work with people. Yeah, so to me, it's really heartening that the peers are being recognised. The value of peer work and of that lived experience is starting to become recognised and formalised. And I know that frightens some people as well. Like, I guess in my experience, it's fairly unique in some ways, because I've also kind of studied counselling and been, you know, from an academic lens as well. And I think have a good ability to kind of to integrate both, or to separate both in a sense, to be able to be in the peer space, but also and be fully engaged with someone, but then to stand back and kind of be mindful of watching for things like kind of projection and power, and the way that I'm using, you know, my language to like kind of convince someone or persuade them for ideas of transference and counter-transference, stuff like that. So, you know, that's not to say you need those skills to be an effective peer. But for me personally, I think it's been helpful in terms of like boundaries and being able to like see things more clearly. And so that would be the other thing that I would say also. I think what works well, particularly in the team that I'm in, is that we've established strong relationship and rapport with each other, so strong working relationships, and I get excellent supervision. I feel that I can talk about anything that comes up for me, and will be offered varying kind of perspectives around that. So as organisations, I think, you know, there's a dual responsibility. There's responsibility from peers to be as transparent as they can be with their organisations about what they're experiencing, what they're maybe fearing, or when they're getting into territory that kind of seems a little bit grey. Because it's not all black and white, this work, and that's part of what I love about it. And I think a lot of people that are in this sector enjoy about it as well. You don't always know where you stand, you know. Clients will throw things at you that you kind of you have to respond to in the moment, and sometimes you get it wrong, but you get to reflect on that. If you've got good supervision, you can talk about that stuff and work it through. And kind of, you know, there's countless times where I've made the wrong call, and it's only through that sort of analysis and reflection and decent supervision that's made like all the difference. So I think like organisations have a responsibility to do what they do well, to have clear expectations and clear boundaries set out, and policies and procedures, all that boring stuff that, you know, you just sometimes you just want to be gung-ho and go for it, and you know, and address the pain and the need that you see right before your eyes. But, you know, I think that there can be a fear sometimes amongst peers that for professionalisation of skills, that they don't want to, people don't want to lose this natural kind of energy that they bring to the picture. And in my experience, it's not been the case. Like, it only can enhance what you do. You'll never like lose that rich experience that you've lived. You'll just find different lenses to kind of to view that through, and ways to apply that to real world experience and one-on-one interaction with people. So just talk a little bit about, so the role that I'm in now is the reducing harmful drug use through peer-led networks. It's been funded. Geelong was acknowledged as a hotspot amongst a few other places. And so we really had to think about this funding. You know, it might only be a year, 18 months. It was uncertain how long it would go on for. So what kind of could we create? We didn't want to make something where when the funding ended and the peer had to step out of the role, that the work couldn't continue. So the majority of the work that we've been doing is focused around Take Home Naloxone program and naloxone training. So overdose awareness and prevention. And the work was, it was going before I came on board as a peer. And I'd been part of that work in training people through the NSP as well. But we've trained over 800 or 900 people now. I haven't looked at the stats for a little while. And of those, we've had reported roughly 25% of people have reversed an overdose with the naloxone that they've been provided with. So 1 in 4 generally of everything that we give out, we know gets used, and people report back to us, and then they want a top up, they want to get some more. And we also hear anecdotally that it's used by people that we haven't personally provided to. It gets shared amongst friends. So we know that those stats are probably low. They could be a little bit higher. But one of the interesting things that we found from our stats, so if you remember, 1 in 4 or 25% of people that are trained, and this was by all the staff. So we have people that do MATOD, like pharmacotherapy, NSP workers, people working on a systems level. All of us have been trained to train other people, and 1 in 4 report that they used the naloxone. But that's so 25%. But for the people that I've trained as a peer, it's over 60% of people report using a reversal, having done a reversal and then coming back to get more. So I find that that's really interesting, you know, as it may be that the people that I'm seeing are the more risky ones, or the ones that are willing to engage and kind of like tell me more, perhaps. Like, I don't know that, yeah, I don't want to like big note what I do or dismiss the work that my colleagues do, but the stats are showing that there's something different when a peer is training people in overdose prevention and awareness, and it's coming through as a huge increase of people that are actually using it and taking that information on board. So I think peers are integral to that kind of to building that trust and the ability to engage with people in a slightly different way. You know, people kind of look at you and suss you out, and sometimes I'll ask, you know, oh, have you been there? Have you been where I've been? Oh, I can tell, I get this sense. But yeah, it's, again, like, I like to reflect on this stuff. I don't think that I have all the answers by any means, but I think that is a really powerful and an interesting statistic that we could probably do more research on. And another thing, I guess Sione touched on it before, is about funding of these things. Like, we know, you know, not just for myself, but I've gotten to know other peers through the networks as well, peers that have been employed. And there's some brilliant people out there, really passionate, doing fantastic work. And one of the things is stability. You know, you can't. It takes a lot of time for people to become stable in their lives through their using or whatever. Or some people are up and down. People coming into the workforce as peers have sometimes had these huge kind of gaps in their working life. You know, that might be generalisation for some, but, you know, for others, I know that that's exactly the case. Like, there was a lot of kind of time out and gaps in their resume and work history and stuff. And so to be able to use their experience, their lived experience, as a real foothold in, you know, and to have an organisation that will employ a peer, you know, will take that kind of opportunity to draw on lived experience. That's amazing for someone that, you know, might have thought that they've stuffed up their career. They've had no career path. You know, they're just trying to like piece things together at some point when things get clearer. And so the stability to be able to be a functional peer, you need stability. And around, you know, it's a little bit political or whatever, but around the funding situation as it is, you know, I had to leave the role once because it wasn't clear whether it was going to be refunded or not. The funding approval came through after my contract had ended and I'd already left the job. So I was lucky enough to be re-employed again for a second round, but I find myself in that same position again. You know, I'm 2 mortgage payments away from being unemployed and I still don't know if I'm going to be employed. So just for any funders or for DHHS to take that on board, like that, yes, this is a kind of pilot, it's a test it and see how it's going to go situation, but if you want to get those good workers and keep them building on the foundations of the work that they've done, there needs to be some kind of assurance or for things to kind of like roll over in a more long-term way.
Some job security there, David. That's yeah. David Bean, sorry, we're getting a lot of questions through now, and I did want to go to Stephen McNally from the Pennington Institute before we go to the questions. So please do keep your questions for both David and Stephen coming through on the YouTube comments, and we will get to them shortly. I saw that there are also some questions for Sione and Graham as well. For anyone that we've missed, we will also be doing some questions at the end. So we'll go to Stephen McNally now, who is the Deputy Chief Executive Officer of the Pennington Institute. And Stephen is an accomplished researcher with a track record of developing policies, programs that improve the lives of marginalised communities. Before joining the Pennington Institute in 2015, Stephen was a senior research fellow at La Trobe University, and sorry, I'm multitasking here, reading it. And today, Stephen is leading Pennington Institute's workforce development and research policy teams. And there he is. Stephen, welcome.
Thanks, Nick. Thanks for the invite, and David, thank you for that presentation you just gave then. Really showing the complexity and the challenges that this area faces. But I just want to start by, I guess, reinforcing the importance of peer participation in harm reduction services, and the benefits of using peer support for building that service delivery and making the service delivery so much better. And also, I wanted to just to note that in the harm reduction sector, we have been doing have been employing peers for a long time. So it's not something that's new. And if you look at the primary NSPs, needle and syringe programs in Victoria, they were originally managed and staffed by peers, although what we've seen in more recent years, there's a lot of variety there in the professionalisation, and some of the staff, they are peers, but it's not reflected in position titles. But they were being employed because of their close connection to the client population, and because of the personal lived experience that they bring to that role. What I want to talk about in these few minutes is, and it's the program that David is involved in, and Danny, I guess you're going to be talking about this program too, and Sione mentioned it as well, and it is the Reducing Harmful Drug Use Through Peer-Led Network trial, which is a bit of a mouthful. And it's also sometimes referred to as REDUPLIN or something. I think that's the acronym. It involves 6 organisations in Melbourne and the Geelong organisation where David is. Those organisations were chosen simply because they were the hotspots, and DHHS funded this program probably about 3 years ago, and Penington Institute's been involved in the evaluation. We're just finalising that evaluation now, and I'm just going to reflect on some of the issues that have come up through that evaluation, which I think is going to add to the discussion, and to add to it in a way to show the complexities and the challenges that we still face in this area, and that it's there's a lot that we can learn from this program, and it sort of shows that there's a lot that I think still needs to be invested in, and that I want to just go. I'll just sort of highlight 4 points from this program, which I think will give you some insight. It's with these 6 organisations, they're all very different. They're doing very different things in that their client groups are different in some instances, and also the organisations are really different. Some organisations have a history, as David was saying then, have a history of having peers within the organisation, or they may have peers that come from other sectors within the AOD, but not within the alcohol and drug sector, but not from within the harm reduction. And I think what we're finding in the harm reduction space is that there's a lot to learn from what's gone on in, say, the mental health space and in the treatment space in regard to supporting and working with peers and integrating peers within organisations. And I think we're going to be seeing a lot more of that, and I think that's an area that APSU Harm Reduction Victoria is sort of working on, which Sione mentioned earlier. But going back to what the four points are that I want to really bring out today, and the first one is, and it's one of the most important topics addressed, and it's something that's written about, it's discussed a lot within this space of peer-based work within the harm reduction space, and that is integration of peer workers into the harm reduction organisation. And it's there has been a shift in how peers are understood and how they're valued. And this what David was really talking about then, that there's a growing recognition of the role of peers and what the role of peers play in the harm reduction sector. And we see this, I guess, in simply this trial that's been funded by DHHS across these 6 organisations, and the investment that the department has given to that, and the importance that they've given to the role of peers. But I think there's a lack of peer integration into the harm reduction services, and what I've heard from some organisations that at times there's a bit of a struggle with programs such as these seen as sort of add-ons or standalone programs within organisations? And maybe that's sort of a bit of an evolutionary process, but we sort of need to acknowledge what that means for organisations. And some of these organisations, these 6 organisations, have not had peers working in this space before, or haven't had peers working in this space for a long time. So haven't necessarily been equipped or ready to do that work. And they've discovered that it is a really challenging area. To make sure you've got all the support and you've got the support ready, and it's going to be a good experience for everyone, which is for the organisation and for the peer worker. The second one, it's in the title of today's panel, and that is it's sort of the biggest challenge that we face in this sector, and it's the criminalisation of drugs and the stigma associated with that. And that's come up again and again in this in the reflections that have come back to me in regard to the evaluation. And it's a huge hurdle. It's a huge hurdle to navigate. And that for some of these participating organisations, the most significant and the most notable achievement for the organisation was actually employing a peer worker. And what that meant for them was really negotiating internally with their human resources department, and that's getting a position description, a PD that actually states it has on their peer worker, and also the challenges around the organisations getting police checks, which is something that is required more and more, if not all the time now. And how you go about doing that, they're not small achievements for the organisations to do that, and they're really important ones too. That having a peer worker in the title, or making sure having that within the position description, they're notable changes that we are seeing in the sector. And these things are reflected or seen more in other sectors where it's easier to have that because of the stigma is very different, and the criminalisation is not an issue. So it's an important point. The third point that I want to make is it's an ongoing challenge to achieve that meaningful involvement all the time with peers, and making sure that they have the best peer-based programs possible for them. And what I'm talking about there is it's really that some of the feedback that I'm getting through the evaluation is the sports that is needed. There's needed to be a greater investment, I guess, in regard to making sure that there's a supportive environment within the organisation, that the broader staff, if it's a big organisation, the broader staff understand and appreciate what a peer worker brings to the program, and what the peer brings to the organisation. So it's there's a lot of work. There is a lot of work, and in some organisations, there's been a lot of work done over the last couple of years in that space. Some great achievements, and it's another area within this third point is really the capacity building for peer workers, and that's something that's needed, along with the developing of programs, programming and policies, that a lot of organisations don't necessarily have all the policies and programs in place in regard to when they're employing peers. So there's to employ a peer, it requires a commitment and an investment by the organisations. And it's played out in a number of ways through that supervision, mentoring, the importance of that. Because peers are employed, or they're chosen, or they're employed on the basis of a range of things, and their experience with drug use and their connection to the community is obviously there. But and perhaps they even live in the community, that brings a whole range of other challenges for the peer worker, and there's more support that's needed to be given to the peer worker. So there's a lot of extra work that needs to be done within organisations. So employing a peer can also require much more orientation to the job, and sort of the skills that are needed, which sometimes are just taken for granted. But if you're employing a peer worker, it might be for those other reasons, but then they may not have had a chance to have or to build up computer skills, or to be comfortable with setting up meetings, or even just having the skills and the confidence to get out there and represent the organisation to the community and to other organisations. So there often needs to be that focus on providing that support, which shouldn't be overlooked.
Hey Stephen, is it okay if we start going to a few questions? We've got a number of questions coming through, and I want to start to get to some of them.
Can I ask? I'll just go one more point.
Oh yes, there were 4 points.
And that is what I've found in this program, and it's an important point, is that peers, they provide a really valuable resource in doing outreach work. And a lot of the programs have done in this program, a lot of the organisations, the focus has been on outward or outreach. But the other point that is happening more and more is the inreach, which David was talking about and other organisations have talked about. And that's a really critical part to the role of peers, and the importance of consolidating this whole area is turning into the organisation, and peers having a role in making sure a lot of these programs are embedded in the organisation, and that people within the organisation understand what a peer does, and the skills and the importance of peer workers. So I'll finish there, and by just saying, I guess, that the program, there's just a lot of goodwill out there, and there's some great achievements that are happening, and this obviously still it's complex and it's challenging.
Thank you very much, Stephen McNally, the Deputy Executive Officer at Pennington Institute. And we've got a few questions now, and bear with me while I reconfigure these again. But I'll go first. One from Dara, who is asking, in relation to drug use, many peer workers who arrive in the sector arrive with the beliefs that they have got from abstinence-based programs. So how is that sort of navigated in a harm reduction space? And sorry, we've got Stephen back there, and Graham as well. Do either of you want to take that question?
It might even Danny, you haven't spoken yet, but I mean, it might be more valuable coming from within an organisation that has done that. The answer.
Would anybody like to answer that or talk to that point? Yes, David.
Yeah, I'd just say a little bit around that. I think there has been a sense of kind of suspicion or frustration, or I don't know. I think like organisations want to play it safe, and you can't blame them for that, so they talk about recovery, people needing to be in recovery, but no one really defines what recovery means. Does that mean that you're abstinent? If you use on weekends and not at work, is that okay? Like if you're on a pharmacotherapy, and so you're basically affected by your medicine the whole time, does that rule you out from being a worker in an organisation? It's just really complicated, and I think organisations make more of a fuss of it than actual peers do. Peers know what they're capable of, and within limits and reason, of course. But I think it's safe, and it can be it's like stigmatizing and discriminating again within like that substance using or ex-substance using community, however you want to say it. well, you're not a real, you're not a real peer unless you're using, or you're not really helpful unless you've recovered. I just think that's a conversation that's ongoing and really complicated. There's no simple answers to it.
And an addition to that question from Pia Giorgio, from an OH&S perspective, and this might have people with their workplace policies might like to talk about this, but what are the guidelines in terms of drug use, i.e. having drugs in your bloodstream while at the workplace for peer workers? And I know that that's a question that we've certainly wrestled with at Harm Reduction Victoria over, even when I was a board member about 5 years ago. We were running through policies, and would anybody like to talk to that one?
It's like any OH&S.
You muted yourself again.
Right. It's like any OH&S. It really is like any. Lots of organisations have got drug and alcohol policies, and as a harm reduction organisation, we would never have a zero tolerance policy or an abstinence-based policy. It's really like any work health and safety policy. It depends on the circumstances that you're talking about, and it depends on your risk appetite as well. And obviously, a peer-based harm reduction drug user organisation like Harm Reduction Victoria might have a bigger risk appetite than other organisations. Our perspective would be that there are numerous other dangerous or challenging circumstances around drug use other than actually being drug affected or having drugs in your bloodstream, including the criminalisation and the stuff that can happen to you outside of work. So I think that it would depend on circumstances about whether or not someone was driving and about whether or not they were on medication and that sort of thing. But it's certainly for each organisation to work through. But there's no point having a peer program that is zero tolerance based anyway.
We're going to get to the rest of the questions after hearing from Danny Jeffkett, because I want to get to Danny before. We might be running a little bit over 2 o'clock, so if you do want to stay along for the stream, we'll go into some extended commentary and questions there. And I just wanted to say on that question about workplace and drugs, because the question specifically related to drugs in your bloodstream, I think it's really important to note that over the past decade, we've seen a real increase in workplace drug testing, led by a couple of companies that sell the tests, funnily enough. And I think there hasn't been enough questions going on around that, because those tests are not impairment based. They're not like blood alcohol content tests. This goes the same with roadside drug testing. These tests do not distinguish between impairment and presence, and that is an issue because the stigma of impairment is applied to anybody that fails these tests, even though some of these tests can detect have a positive detection days or weeks after somebody has taken something. And if you want to sort of analogy, if you're somebody that drinks alcohol but doesn't take other drugs, there are also tests out there where you can test for certain enzymes, I think, and find out if somebody has had a drink at any time over the past month. So imagine that you were on the road and you had that test and you were removed from the road because you had drank in the past month, or equally so for your workplace. So that's the sort of thing. It's an issue for another day to discuss in more in depth. Right now, I want to introduce Danny Jeffkett. Danny is from CoHealth Western. Danny, I'm just going to let you introduce yourself because I've got to get you on screen. So, Danny Jeffkett.
Thanks, Nick. Hi, I'm Danny Jeffkott. I'm from CoHealth AOD Response West. So the AOD team's in Melbourne's West, based out of HealthWorks. So for this presentation, I was asked what a health organisation needs to ensure a robust and supported workforce that includes peer workers. So first, I think we need to set the setting. And the setting for service delivery is one where you have multidisciplinary teams built around to respond to groups of people. Peer workers are integrated into the team along with other professionals. So it's a setting where personal experience as well as academic experience is valued. And that integration really is the strength of the team. When I thought about what we really need for a robust and supported workforce, I think it comes down to three main things. The first one is clear guidelines that define the work. So that's, as David was saying earlier, that's the boring stuff perhaps around position descriptions, having clearly defined scope of practice so people know where the boundaries are. The second thing you need is effective partnerships and networks. So the relationships, that's what makes any worker effective, is the people they interact with, the people who provide support. That's both internal to the organisation and external as well. The peak bodies, the external networks. Internal, it's your team, your manager, your colleagues, the other people you interact with. The third, and I think one of the most important things that you need, is an empowering and supportive culture. You can have all the policies and procedures you like, but culture will eat that for breakfast if it doesn't align. Excuse me. So having a supportive and empowering culture really is what defines the success or not of having peers or any other workforce development really successful. So if having a successful culture, if that's the secret sauce, then the essential ingredient really is leadership. So when I was preparing for this presentation, I went and asked some of my peer workers what was important to them. Excuse me. One of the things that the first worker said to me was, good leadership is really what defines and supports her to do her work. And she reflected on a time when peer workers were under attack in the newspapers and the uncertainty that caused for her. At that time, our executive officer, Nicole Bartholomew, sent an all-staff email backing peer workers and saying that they are an essential component of our workforce. And receiving that email really felt supported and effective in doing her role. So, got to cough effectively these days. So those are the three simple points: clear guidelines that define the role and the scope of the work, effective partnerships with colleagues and stakeholders, and a supportive culture will really define and develop successful workforce. That's it in a nutshell.
Excellent. Thank you, Danny. And I guess we will bring everyone in now. Let's see if this works. It's going to get a bit Brady Bunch. This is the Yarra Drug and Health Forum. We are our first online forum, and I'm going to bring everyone on screen so that we can go through a few questions. And let's just center some people, make sure that they're there. So I'll just start asking with... are there good practices? This is from Karen. Are there good practice examples for the supervision and support that peers should have? And I'll open that up to anybody that wants to answer that, feels like they have an answer. So please, so please, if you think you have an answer, let's hear it.
Danny?
Effective supervision happens both internally but also externally as well. When we were setting up the project that Stephen was referring to, one of the things that was important in setting up the program was having a relationship with Harm Reduction Victoria and with APSU to provide supervision that was external to the organisation and develop practice there, as well as the organisational line management supervision. So having both avenues was considered to be very important in the development of the program.
And I would add to that, we're sort of developing this as we go along, and one of the things that's needed is as I mentioned, is a workforce strategy really that can address a number of these issues. But Danny's right. We also have peer supervision in terms of groups of peers getting together to talk about stuff. And as well as that, so in our circumstances, we'll send all of our workers who are part of the peer organisation will also get external supervision as well. So they can manage any issues for them that come up. But obviously within the organisation, we also provide supervision because we are peers as well. And so we can at least talk about particular issues that we can that we have lived experience of and can relate to together as well. So it's a bit of a mix of all those things. I think Danny's right overall, but those two things are really important for external orgs as well.
A question from Jennifer Keane McCann, one of the volunteer lawyers with covidpolicing.org.au. If you haven't checked that out, please do, covidpolicing.org.au. Jennifer is adding to APOD support's question, which was, are peers currently on government AOD health working committees or advising ministers? And Jennifer was asking what approach can be taken to incorporate lived experience into policy. Who would like to take that one?
It depends how you define these things, but I would say that certainly in the BBV world and in AOD space, I think that, you know, organisations like Harm Reduction Victoria, APSU, Shark are absolutely engaged in processes. Sometimes those are committees, sometimes they're conversations, and but I would say that really formalized, ongoing, never not do it consultation is a little way off. I think consultation happens, but including it systemically so that peers are always consulted on things that affect us, that's a little way off. But I think certain parts of the government do it quite well, and not all organizations do it very well, but some do, including us.
Any other comments on involvement from on panels on you know, as part of the decision-making process on policy? Has anyone been a part of policy making?
The only comment I was going to make, so it's Graham here, was I suppose being on the committees of which, you know, Harm Reduction Victoria and a lot of the other peer organisations are on. There's a couple of key things. It's back to a lot of the points that say Stephen, Danny and Davey made, is around not only being on the committee, but the insights of peers actually being culturally valued by that committee, by the organisation and so forth. And that is achievable and does happen in some of those environments. I was fortunate enough to even be on one committee where the committee cancelled the meeting because we weren't going to be able to have a peer drug user at that time. Unfortunately, that's not the majority, and yet sometimes it'll be cancelled if someone else on the committee can't make it. And so it's that kind of equity of culturally valuing the insight that I think we can aspire to, and I do believe we can achieve.
I think that's another really good point. Just really quickly, there's often one peer or one drug user or one person with Hep C or one person with HIV on a committee, and that's one of the reasons why sometimes our voice can be drowned out, but B, often there'll be no voice, because if we can't make it to a meeting, that's that. And so we're constantly feeling the pressure and being pulled to a range of different places because it's important for the community, but we're not always available.
I know personally, I don't know if this sort of counts, but I, as part of the Victorian government's inquiry into drug law reform, which made 50 recommendations out of a 650-page report, I went and spoke to that as part of the DanceWise program. How much of that was actually integrated into anything, that's a different matter, and you can talk about government inquiries and the effectiveness of them when it actually comes to doing something with those recommendations for a lot longer. But I've got some more questions here. Chloe has one for Sione and Graham. Do you see the W3 model incorporating family peer workers?
Okay, so by that I'm presuming you mean sense of the, so if we're looking around people who use drugs, family members and so forth, so in that sense. Where I've probably seen that most effectively used has been probably more in slightly different, like the HIV context of families being affected around HIV and that sort of aspect. What I bring it back to is, depending on the peer program, what's the role of the peer to actually play within that program and within the system they're actually operating? And in those contexts, if it is, if we're talking around peer in the sense of family members of people who use drugs or family contexts and so forth, if that's the focus and that's the emphasis, then it would make sense. But it really comes down to whether or not others are actually engaging with that person as a peer and see them in that context, then allows the kind of interaction to be really effective. The other part is, which speaks, I think, some of the other points, is peers need to be engaged, whether the drug is or not, within that broader understanding of what's actually going on, and not sort of positioned against each other. I was just thinking back to the other aspect where, how should I put it? Oh no, it's a different question, but it was, I'll come back to that and stop waffling.
Another question from APOD support. In mental health lived peer... Oh, somebody's just dropped it off screen. Now I know what it's like to be on ABC 774. There we go. Workforce is integrated with in clinician teams in mental health lived peer, in the mental health lived peer workforce. How can this sort of thing happen in alcohol and other drugs?
Could I?
Yes, David. Pick these up. Yep.
Yeah. So the setting that I work in, there's a drug. Excuse me. There's a drug treatment team and there's a harm reduction team. We both work in the same building and we collaborate with each other. So quite often the clinicians who are involved in treatment will refer to the harm reduction team or just come and have a chat about, I've got this client who's using this and that and that. What could I say to them, that might help? Or do you want to sit down and have a chat with them? So it's already kind of cross-pollinating, and we sit in meetings together, clinical meetings, and so that they learn more about our world as harm reductionists, and we learn more about theirs, challenges as clinicians as well. And that's a really helpful space to be in.
Oh, Peter.
Oh, yep, Peter.
Just to jump in there, one of the things in terms of structure in mental health, disability, and other areas, it is unthinkable that you wouldn't have, as part of any funding structure, people with lived experience or peers as part of the funding mix for any service. And I think the answer to this goes to structurally putting in the money into funding agreements and funding models that actually embeds that sort of expertise and that sort of role in every AOD treatment service, any AOD treatment team. And I think that David's point earlier, that he had to resign from his role to pay his mortgage, only to be re-employed when the funding came through after he resigned, to be re-engaged. It's about what we value. And Danny talked about it, Sione's talked about it. It's been talked about by a lot of the presenters. If we don't value this work, we won't fund it. If we fund it, it's the first sign that we value it as a society and as a government and as a structure. So I think it's got to move from being experimental and sort of something we might do when there's a bit of money around to be embedded in the system. And Sione's point, every time you have a meeting about the treatment sector or drugs in this society at a government or any sort of authority level, it should never meet without peer representatives as being part of that mix. Those committees should never meet without having people as part of, with that perspective as part of that mix. That's when you know we're taking it seriously.
Another question from Chloe, who directs this one to Stephen. Stephen, earlier you were talking about capacity building for peers being really something that's important to do. How can you please talk to what you mean around capacity building for people who use drugs?
Okay. I think it's acknowledging as with everyone that comes into positions, you come in with a range of skills. A comment that was made from one person that I interviewed for this evaluation was that often when people get new jobs, they're stepping up to that job. You know, that when you get a new job, you don't necessarily have all those skills, but you grow into that. And we've all had experiences of that in the work that we do, that you've just got this opportunity, but you don't necessarily have all the skills for that. And it's acknowledging what needs to be worked on. And sometimes it's also in this space acknowledging that for some people, for various reasons, and it might be legal reasons, that they do have a criminal record, that they haven't had a job before, you know. And so it's like, well, what do you need? What's the extra skills that you need to be instilling in people or supporting people to get? And sometimes those skills are really fundamental. And other times they're not. You know, other times you're employing peers that have a range of skills that are able to just step into an organisation, but can do everything. But it's acknowledging that some people in this area too, I think that they don't always get the breaks, and if they do, and they're stepping into a position that maybe they don't have all the toolkit, you know, everything that they need. And it might be really simple things that it might be simple computer things, or it might just be how you go about negotiating or conducting yourself in a workplace, all those policies and procedures. I mean, all of us, I imagine, have trouble wrapping our heads around policies and procedures within organisations. The best of days. So that's what I was referring to.
Thank you, Stephen. There's been a lot of commentary on representation of people who use drugs in the policies that are being made around them. Not so much questions, but just people still shocked that stigma still plays such a massive role in our drug policy making. Just wanted to know, maybe because it is 2:00 now, so we'll finish up shortly, but maybe just we'll go around starting from that way, starting from David. Just some comments on how you think our drug policy and our drug laws could be improved for people who use drugs, for those that require treatment, for those that don't. What's like a number one core improvement that you would like to see?
I think for people to be given the opportunity to have their skills and their abilities or whatever go forward rather than their reputation, you know, or their past. Like if someone's capable of something and they can pass an interview and they're competent and they've got the skills or whatever, that that should have more weight than what they might be doing or what they might have done. Like, you know, if someone conducts themselves as a decent human being, you know, they should be given the opportunity for their history or fears not to, dictate their future.
Danny, we'll go to you now, moving clockwise around our Brady Bunch squares.
I think one of the things that really separates out peer workers in the AOD context from other sectors is the criminality of like their connection to criminal behaviour, and their ability to fully participate is going to be limited by that, and because they need to limit their exposure to serious repercussions potentially. So until we can address that, until we can address and make it safe for people to be able to have their voice heard, we're always going to have limited capacity for people who use drugs to fully participate in those environments.
Moving just slightly sideways to Sioti.
Thanks. I'm going to have two things because I always do. One is drug law reform and decriminalising drugs, but something that we can reach for now is a fully funded and thought through workforce strategy for peers in AOD harm reduction, and have that delivered by organisations, like ours and APSU, and in consultation with workers who currently exist, so that we can answer a number of the questions through a strategy that we've been talking about today.
And down to Graham.
I suppose I'd add to the thing is if we're going to achieve really good participation in like the workforce that Sione just mentioned, I'd be keen to also see a program about developing the capacity of organisations to support peer programs. So some of the logistical sort of and policy challenges that Stephen spoke to, but also those cultural aspects that I think if we can achieve that, then we'll get a lot more effective peer participation and influence.
And finally across to Stephen.
I think people have pretty much said it in regards to the decriminalisation, dealing with the issues around stigma, the internal investment within organisations, the cultural change that has to go on. Sorry, that's too many. It's stuff that everyone has said.
Yeah, it's. Peter, did you want to final comment there?
Yeah, are we hearing from Andrea, Nick?
I haven't got her on the Zoom call, so I'll just have to mention that one.
Okay.
Yeah.
Okay. Do you want to mention the next one, and then I'll finish?
Yeah. I guess. All right. Well, since we're going to do that, I'll go back to over here. Thank you to our guest speakers today. We've got in the top left corner David from Barwon Health. We've got Danny from CoHealth West. We've got Graham Brown over here from La Trobe, and we've got Stephen from Pennington Institute, and finally Sione, who's just above Peter there. I can't quite reach him, but Sione Crawford from Harm Reduction Victoria. Full recording of this will be available on our YouTube channel, so please do hit subscribe and subscribe to the Yarra Drug and Health Forum YouTube channel, because we'll be doing more of this sort of thing in the future. So again, ydhf.org.au is the website. You can get in contact with us there. And I just want to, before Peter takes us out, just wanted to say a quick thank you to the Executive Officer here at Yarra Drug Health Forum, Bernadette Birchall, who put this together. To CoHealth and the City of Yarra, both supporters of the Yarra Drug and Health Forum, and of course again to all of our speakers and their respective organisations, and also to you for tuning in today. We would love any feedback that you have. We will be doing this again likely next month, and would love to know how it's sound, how it's looked. I know there have been a few things that I'm hoping I can fix next time, but we're going to cross to Peter now, and yeah, thanks very much.
Yeah, so we also need to thank Department of Health and Human Services also for providing funding, as well as the City of Yarra for the Yarra Drug and Health Forum. But look, I'd just like to thank everybody that contributed today. This is a really important issue that the sector needs to confront and to deal with, and the calibre of input today has been outstanding. So thank you so much, guys, for everything you've contributed today. And just to end, really, the strength of this sector has always been its ability to link the brain with the life, with what is going on now. The lived experience is so important in forming the knowledge and the research and the science. And together, this is going to provide a way forward. And this is the beginning of a conversation. And it's so encouraging to hear such really, really articulate and clever people that are involved in talking about these issues. And to the workforce that has lived experience, on behalf of the Yarra Drug and Health Forum, we acknowledge you and we thank you for what you bring. So thanks, everybody, and stay tuned.
Next Next month, we will be hearing from Andrea Cook for the June 1st, I believe, is the date. But keep an eye on our website, ydhf.org.au, social media, Facebook, also on Twitter. We may experiment with doing things like having some Twitter conversation in the future, if that's something that would help people. But the comment section on the YouTube account has worked well. That's where you're watching it. You can drop the comments there. It's nice and easy. So Andrea will be continuing the discussion about community engagement of drug users in the wider conversations. Thank you very much for joining us today, and we'll see you next time. Bye-bye.
Well done, Nick. Good stuff.